Good morning, everybody. I have been told we're having some webcam issues. I apologize for that. We'll get that worked out in the future series. So for today, it looks like we're only going to have the slide presentation, and you'll hear my voice. If you have any questions, please feel free at the end. There's a time set aside for questions. Welcome to the Ask Rural Louisiana series. Before I start, I want to make a couple of disclaimers. We have to put that in, of course, that there was no cost to this agency for printing or for and we don't have financial interests or arrangements with any of the organizations that are mentioned in this, and no financial interests or arrangements, real or apparent conflict of interest with any of those agencies. So now I'm going to jump in right to the heart of the matter. This is the second in the series, and I wanted to point out, I know some of you may be asking why it's the second in the series of Ask Rural. The first part of our series was a very targeted series of webinars that are continuing, but they were targeted for emergency preparedness for the 16 additional clinics that were recently affected in the new emergency preparedness rule. So those have been ongoing. They've been very, very successful. We've got a lot of callers and questions from those, and the webinars have been great with participation. Thanks to Nicole Corsi and Avis Richard Griffin, that's been going well. So we wanted to build on that momentum and go right into this whole series. So that's why this is going to be the second in our series. And there will be more coming. There will be opportunities for webinars with the primary care office, questions about HIPSAs, different parts of the Bureau of Primary Care and Rural Health. They will have different sections and doing webinars for you. I will also be doing a separate webinar in this series specifically related to technical assistance for rural health clinics, because that is one of the things that we get the most questions about, and I can get a little bit more in depth in that webinar. I'm not going to go real in depth with that today, so you'll see some just overview information about that. As always, feel free to contact us if you have questions for anything that's mentioned in here, and we'll be happy to help you. So why we're doing this, we're on the overview page. We're doing this to reach out and for not only partners within LDH, but outside of Louisiana Department of Health and Office of Public Health, for people that may have questions, communities, hospitals, OPH, anybody that has questions about what we do in rural health. Sometimes there are misperceptions and misunderstandings about, say, the different clinic types or the different types of hospitals. And we want to get the word out of what we do and where we can assist. So an overview of what we're going to be discussing is what is rural. That's one of the most frequently asked questions in all of this. I will go into specifically the State Office of Rural Health under the Bureau of Primary Care and Rural Health, where we fit into the overall LDH governmental picture, whom we serve, what we do, our partner agencies and different organizations, what we do specifically on development and sustainability, more general information about rural health care, and moving forward, where do we go from here? And of course, the last part is going to be my contact information. The last slide, or somewhere at the end, you should see mine and Denise Dow. We both work in the State Office of Rural Health, and we're always happy to take your questions, and we'll do our best to get back with you really quickly. Our learning objectives today is designed to help your participants to better understand what the definition of rural is, what it means to you. Not just the definition, but what it really means in the bigger context. Identify where SORH fits into the overall Louisiana Department of Health, who we serve, the goals of the State Office of Rural Health, and how SORH works with rural communities. And then lastly is know how to contact us. To me, that's kind of the most important part. If you have questions, when you have questions, please contact us. What is rural? I always hesitate when somebody asks me, well, what's rural? Or send me a rural map. One of the things you need to understand first off the bat is rural is, there are about 15 different definitions, federal definitions that are used through different agencies of rural. What we use often, the most often here, especially for the Rural Health Clinic program, is the U.S. Census Bureau definition. And it's unique in that rural means basically anything that's not urban. So when you look at rural maps under the Census Bureau, you'll see urbanized area or UA. Anything that's not marked as an urbanized area is rural. Even when you see an urbanized cluster, that's still considered rural. So there's some confusing things even when you look during the Census Bureau. But then when you're working on additional projects, say you may be doing grants or things like that, you have to really understand and look closely at what definition do you want us to use for rural. For instance, the Federal Office of Management and Budget, they designate counties not as necessarily rural or urban, they designate them as metropolitan, micropolitan, or neither. And under their definition, metropolitan area is an urbanized area of more than 50,000 or more people. Now that also can encompass the surrounding areas. So anything that is not metropolitan is considered rural. That's just one other organization. It's a big one. Office of Management and Budget is a frequent one. Census Bureau is the most frequent, and then I would say OMB is the next most recent definitions. But if you're working on grants or different projects, it's very important that you look at what definition or what agency you're looking at the definition of rural or micropolitan or metropolitan, what they're using, because there are so many definitions. And of course, the maps all change depending on what their definitions are. For instance, we just went to a meeting with the CDC and HRSA, and they're using the Office of Management and Budget designation as rural, whereas a lot of their programs uses the Census Bureau designation. It's the OMB's definition is a little bit easier to understand as far as data and mapping and things like that, and quantitating healthcare information. But specifically for the RHC program, we have to use the Census Bureau. So I know it often seems to me like I'm kind of evading the question when somebody says, what is rural? Well, that's because there's so many definitions, you know, and I really have to ask, what are you trying to work on? What are you trying to do? So, and understand that so I know what definition you're trying to get at. I want to go into briefly how we fit in. We are under the Louisiana Department of Health, and we are in the Bureau, the Office of Public Health is under the Louisiana Department of Health. We are under the Office of Public Health, and within that, we have the Bureau of Primary Care and Rural Health. Our director is Avis Richard Griffin. I'm with the State Office of Rural Health is one of those divisions under the Bureau of Primary Care and Rural Health. We have health systems development, we have rural health, we have the primary care office, the small hospital improvement, the Medicare rural hospital flexibility program. There are different parts of the Bureau of Primary Care. And like I said earlier, I'm really going to focus mostly on the State Office of Rural Health part for this presentation, because the other areas will be doing their own presentation. But one thing you need to understand is part of our role as the State Office of Rural Health is to be that cross-sector connector, okay? So if you have a question that is maybe better for the primary care office, I can connect you to that. If you have questions, and we cross over and we work very closely with all these other programs, not only in the Bureau, but in LDH overall, we work very closely, because that helps our program and it helps the people that we serve to get to what they need very much more quickly. As the State Office of Rural Health, we get a federal grant to help support our program. And in that grant, there are 3 overarching goals. And it comes down to simply communicate, collaborate, and provide technical assistance. Communicate is just what I mentioned before. It's to facilitate information to and from rural areas. So if somebody has questions about rural area, you know, I take those questions in. If the federal office has information that they need to get to rural providers, I facilitate that connection. if a rural provider has something that they need to go up to the federal office, they're free to do that on their own, but it's easier to go through me, and then I aggregate that information and make sure the federal office knows. I do that. So the State Office of Rural Health is the connection between the federal office, the state LDH, the Bureau of Primary Care. We're kind of that link to rural for you, kind of a one-stop shop of where can we connect you and where can we get you information. Now, I will be the quickest to say I do not know all, but by any means, but I can usually connect you with the people that do, and especially for the program that you are trying to work on or trying to develop. That's one of the strengths of our program is our many, many partners across agencies, inside and outside, federal, state, local, everywhere. The other thing is to collaborate, because an important part of doing that is that we're not duplicating what other organizations do. We work with Louisiana Rural Health Association very closely. We work together so that we're not duplicating what we're working on. The same thing with the Rural Hospital Association, the Rural Hospital Coalition. We cross over with many of our goals, but we work closely to make sure that we're not duplicating services or making things more complicated than they necessarily need to be. Of course, that's a challenge being government. You all know that. But as much as we can cut that down, and by working together, that's the State Office of Rural Health goal. The last part, and this is the most frequent that we do every day, is that technical assistance, providing hands-on guidance, technical assistance for what the communities or what providers or LDH participants, whoever needs to do for rural healthcare related services. In that role, we provide a lot of technical assistance to hospitals, rural health clinics, federally qualified health centers, and communities. And then we also provide some guidance and support inside of other agencies to help understand rural, what's available in rural, what are the resources, how can we facilitate that work to move forward. So we serve pretty much anybody that is rural or underserved. That does not mean that we wouldn't help somebody in New Orleans. We do that every day, or Baton Rouge. But we're focused on underserved and rural. So the largest part of our effort goes into rural areas, of course, being the State Office of Rural Health. But we also help to work, and especially other organizations with other offices within the Bureau of Primary Care, help support that primary care in underserved areas. The overall focus is to increase outreach efforts to improve the health status of rural residents. We don't just work in rural just to work in rural. The end-all goal is we want our rural residents to be healthy, and we want them certainly to be healthier than they are, and at the minimum to be at least as healthy as the urbanized, the people who live in urbanized areas, have as much health care access as possible, have the opportunities to get the same programs and services that urbanized areas have. So that's part of why we serve rural and underserved citizens of Louisiana. Our partners, we have lots and lots and lots of partners, and I apologize here if I left anybody off of the list. It was not intentional, but a lot of the partners that we work with, of course, we work with the Louisiana Hospital Association, Louisiana Hospital Coalition, the Primary Care Association, Rural Health Association, Public Health Institute, all of the area health education centers, or AHECs, the Rapides Foundation, some with the Baton Rouge Area Foundation, different foundations that are interested in helping rural areas and underserved areas. We have a lot of national partners, being that connection between state and national, like, of course, the National Rural Health Association, which, by the way, their annual meeting is coming up in May in New Orleans. If anybody's interested, we can provide you information of that. National Association of Rural Health Clinics, because we work with rural health clinics. This is the National Trade Association for Rural Health Clinics. They advocate and educate for rural health clinics. The National Association of State Offices of Rural Health, the Rural Health Research and Advisory Board, and that's one of the 7 research centers across the nation that provides information, research and information to Congress on rural hospitals, rural clinics, and leading policy change. National Association of Community Health Centers, and so many, many others. I mean, it would take sheets and sheets of to take up this webinar of partners, but we have a lot of partners because that's our role, is to help facilitate that connection. So what do we do specifically in development for the State Office of Rural Health? What I mentioned earlier, of course, we have the overall SORH, the State Office of Rural Health grant goals: communicate, collaborate, and provide technical assistance. We work on development specifically. That's the more hands-on what we do. We work with communities, rural health clinics, federally qualified health centers, and hospitals. Those are our most frequent ones that we work with. That's the day-to-day, every day we're answering questions from all of those type of centers. We also, of course, work within LDH on if we're considering changes, or they just need to know what's the difference of those things and how do they affect, and what's their primary goals and things like that. We work within LDH and OPH very closely. We also work on sustainability, not just new development, but if you develop something without sustainability, in my viewpoint, you are doing a disservice to that community. So we need to still be around to say when you encounter those bumps, or when there are new regulation changes coming out, there are new financial things that are coming out. We need to make sure you're aware of that. And when you encounter those issues, how can we help you through that? And providing you technical assistance. Also providing you the information that those changes have occurred, because in many of our clinics, they are very small, and they don't have a lot of time to be going through all of the emails from HRSA and National Rural Health Association, all these different resources that we do. We look at those every single day and determine what should we pass on that's really, really important for those entities to know about. How we're often contacted, it can be from anywhere, essentially. Communities, nurse practitioners, physicians, other partner agencies, more and more other partner agencies. When, for instance, when somebody says, well, I have an issue with a rural health clinic, other agencies will refer them to us because they know that that's something that we're very familiar with, that we work with on a daily basis, that we know the regulations associated with it, and we can provide some hands-on technical assistance that maybe other partner agencies can't provide. That's not maybe their core mission or things like that. We work very closely with health standards, of course, through our agency, because everything we do affects them, and everything they do affects our clinics that we help. So we work with them consistently to make sure that we're on the same page with how regulations are coming out. Is my interpretation correct? I want to make sure I'm sending the right message and getting the right information across, because if not, it can not only hurt our programs, but it can hurt what other agencies do, such as health standards, different organizations. So we really focus on working with our partners. Developing how we're contacted. A lot of times, and I've just gone into communities. I could do this for each of what we do for each of them. But for brevity's sake, for communities, when a community contacts us, we generally assess the needs. They will start with, well, we want something, da-da-da. Sometimes they have in mind what they want. Sometimes it's general of, we just need more healthcare services. So we're able to go in and talk with them about, well, here's what we see that's already in your area. What's working, what's not working? What do you see as the need for additional services? Is there a specific need? Is it a more general need? What are your resources that are already there? So we can share our information on what we have as far as what's showing up as the hospitals, the rural health clinics, the FQHCs, the other HRSA-funded grant programs. Sometimes they're not aware, especially people in the communities may not even be aware of all the services, the multiple services of hospitals or that rural health clinic, or know the difference between a rural health clinic and an FQHC. and different things like that. So we do a lot of information sharing. And then when they get down to kind of an idea more of what they want, we provide technical assistance in saying, okay, here's the types of programs that we know about that sounds like what you're wanting, and provide the process, an overview of the process, an overview of how it's done, what are the regulations, what kind of support can we give to you throughout that process, who are the other players in this that you need to get support from, what other resources are available. So we're that connection point for communities to kind of think through. It's very important to understand, or at least to me, it's very important to understand that we never go into a community to say, this is what you need. This is what you need to do. This is, we will go in and say, based on what you've told us, this is what we see is available in your community. But we don't know that maybe that rural health clinic is having some issues at that point. Maybe something changed, a plant moved or something like that, and they were providing healthcare in the plant itself. We're not going to necessarily always know that on the ground information. So information sharing is both ways between the community and for us. And the ultimate decision is from the community and the provider themselves of what they want to do. We don't make that decision of, we can say, here's what we know that fits. Here's some resources for these. This is what seems like what you're telling me, but they're the ultimate decision makers. In development specifically, we work for new development. We work with rural health clinics and FQHCs, and we also do sustainability, as I mentioned earlier. Almost daily, we're working on new development of rural health clinics, less frequently a little bit FQHCs, but we work with new clinic development and providing them the regulatory assistance they need, how to get through the process, who to call. Remember that people in rural, they're not always sitting at their computer and looking up and Googling and binging all this information. When they can call our office and say, well, I need to link this provider, what's my next step on doing this? And we have that at the tip of our hand, and we can provide that and make that easier for them. And we help to walk them through and get them on their own. We never actually do their applications for them. That is their role, and they have to have buy-in to what they're doing. We do not take over. We provide assistance. Same thing once they get developed. We provide sustainability assistance. But we don't go in and say, you need this, or we have to do this for you, or anything like that. We are here. We almost, in many ways, work like a consulting company, in that if you ask for our help, we are more than happy to help you. But we don't come in and force our way into clinics or into FQHCs. That is not our role. Regulatory, health standards, they have the right and the ability to do that. We are the technical assistance side, or as health standards will tell you, that we're the touchy-feely side of helping communities and clinics. They are strictly regulatory. We're the people they can send to say, here's some suggestions for how I've seen other hospitals do this, how I've seen other FQHCs do this, or rural health clinics. In hospitals, we stay up on the policy, the regulatory, and of course, more and more hospitals are doing rural health clinic development and sustainability. So we work with them specifically on those areas. We do our best every day. We're scanning new information coming down from HRSA and from Office of Rural Health Policy about what's coming out, what's on the horizon, what do we think that's coming out, and what's the immediate thing. We also, this is a big thing recently, is helping sustain rural hospital infrastructure. Right now, it's a changing environment. That's just the way the world is at this point. It's more focused on primary care and not as much acute care, keep people happier and healthier and out of the hospital. So hospitals in this realm are seeing less and less inpatient beds filled. And so how do we still maintain that hospital there for services, which is key to a rural community. But how can they move and adjust to still remain viable and not have to close? So I'm going to go into briefly, although it's several slides, just the differences between RHCs and FQHCs, because this is one of the most common questions I get, that people don't understand the differences. They know they have these things out in rural, these clinics, but they really don't know what the differences are and what they are, who they serve, what their regulations are. And I think it helps all of us to understand those aspects so that we understand why they are the way they are. For instance, if you're in a public health unit, you know, I know I have gotten questions before from public health units of, well, I send the uninsured over to the rural health clinic and they send them back to us. Well, okay, technically RHCs are not required to see the uninsured. RHCs can be for-profit or non-profit. So they're not required to see all of the uninsured that are sent to them. Now, do a lot of them see some of the uninsured? Absolutely, but they're not required to, and they don't get extra grant funding for that. Whereas FQHCs are required to see people that are uninsured, and they get specific grant funding for that. So it's a difference that in your everyday world may make a huge difference to that patient and their frustration level. Well, you sent me to that RHC, but they just turned me around. Well, you know, they don't necessarily have to see all the uninsured because they're a for-profit business. So I'm going to go into the ownership and governance because this is very key. FQHCs have to be a nonprofit or governmental agency. They cannot be owned by a hospital. That's important. It must be a nonprofit agency. It can be a governmental agency. For instance, New Orleans, the city of New Orleans has an FQHC. Hospital service districts, however, can own a hospital and also run an FQHC. That's a newest thing. It's been kind of a shift of what's happening in hospitals becoming more and more intricately involved with FQHCs, which in my opinion is a very, very good thing. But they have some specific governance and requirements. The reason why hospitals directly can't own an FQHC is because the FQHC model is founded on community-run, community-owned. They don't want too many. In fact, there's a specific regulation limiting the number of people that can be on the board and the percentage of their salary that can come from the medical field, because they want it specifically to be community-owned, community-run. They have to have in an FQHC, the board must be made up with at least 51% of true users of the clinic. By true users, that's not, I just got my flu shot there once a year. That is, my medical record is there. When I got a sinus infection, I went to this clinic. I start getting worried when I'm talking to a board who is running an FQHC and they're not users of their own clinic, because that makes me wonder, why wouldn't you use a clinic that you're promoting the services of and you're doing really great services? Why wouldn't you use that yourself? That makes no sense to me. So they are required to have and show that they have to have a majority of users of the clinic. They also have to have monthly board meetings. The board itself hires the CEO and they set the policy and operations, but the CEO directs the FQHC. A big difference is that an FQHC can have a satellite, and we see this all across our state. For instance, David Raines in Shreveport, I think, has 6 or 7 different satellite FQHCs off of David Raines, and so their core site is funded, and their satellite sites are pieces off of it. The funding goes through the core site, and then the core site distributes that funding for the services to the smaller FQHCs or the satellite sites of the FQHCs. RHCs do not have that, okay? Each RHC is individually licensed and is its own organization. Now, one umbrella organization can own several RHCs, but each one is individually licensed, has to have their own community advisory board. They have their own policies and procedures. It's a very separate entity. And that's a big question I get. And why can't I just do a satellite of an RHC? I mean, it's all going to be the same. Well, it's a different licensing process. It's a different process of how you run. And they were set up for different purposes. The FQHCs were set up out of the Civil Rights Act. They were set up to provide service to make sure any and all of all ages that get services, even if they're uninsured. And this federal grant was set up there to provide that. RHCs, their core development was about how we recognize as the federal government that there are not enough physicians to serve every rural population in America. So how do we get mid-level providers, NPs, PAs, LCSWs out there into the rural areas, supervised by a physician, but how do we get them out there and then still be able to remain, have that practice be viable and sustainable for the small areas? So that's when on RHC you'll see that the hardest and most strict requirement is on the mid-level provider. They're looking to that mid-level for direction. Now, of course, there is medical oversight, medical director oversight, but as far as the core of the program, it's designed around mid-level. That's very different than an FQHC. FQHCs were set up to provide all types of care, primary care, mental health, and dental across all ages, birth to death, and typically they incorporate nurse practitioners, but their requirements are really not nearly as stringent on the mid-levels. And there's a lot more data that is required for FQHCs. As far as the development, this is a big split. For FQHCs, it's a federal application process. There are different types of FQHCs, and I'll go into that when the next webinar when we do a in-depth technical assistance about the processes for development. The FQHCs, generally what you need to know today is it's usually a grant process. It's a federal grant process. It's about the program, not the actual physical location of the site. An FQHC can have primary care here, dental 2 miles down, mental health 3 miles down. It's about the program. And they're do this application process for the program itself, where it's and their board are community members. The RHC is a state licensing process. There's a lot of variance in how long it takes. FQHCs, it's usually 3 to 5 years. RHCs, it can be a year to a year and a half. It really depends on a lot of different factors. You know, how on top of paperwork the applicant is, how backed up a lot of different parts of this are. There's a lot of things that have to be scheduled and reviews done and all this. So it's a time-consuming, tedious process. But so any part of that is backed up, it can have an effect on the timing. The FQHC's services. As I mentioned, FQHCs must have primary care, mental health, and dental. Now, the mental health and dental can be by arrangement. More and more, we're seeing our FQHCs then move those mental health and dental services into their facility. They're not required from the beginning to have those in their facility. They must have and utilize a sliding fee scale. But they can have more than one sliding fee scale. They may have a sliding fee scale for primary care and a separate one for dental and a separate one for mental health, because the services, frankly, cost different amounts to provide those services. They are a large provider of care to the uninsured and Medicaid population. They do provide a lot of Medicare, but it's generally about 13%, depending on of their total population. Their primary population is Medicaid and uninsured. Of course, they take all insurances. Most of them take almost every insurance they can possibly take, and they're not required to take a specific kind of insurance, but it benefits them, and it is much better for them to have all payor types than just Medicaid and uninsured. RHCs must be at least 51% primary care. They're very specific. We want them to provide mental health services. We like that. We're promoting that. They're not required to do that. But if they provide mental health services, they cannot be a primary mental health service provider. They, at least 51% of theirs must be primary, what we think of as primary care, physical care. They cannot go over that threshold where their primary service is mental health. They must have a mid-level on-site providing care 50% of the time the clinic is open. If that clinic is open 40 hours, the mid-level must be there 20 hours. Strongest requirement of the entire program. If it's 36 hours, that mid-level has to be there 18 hours. They're not required to have mental health in general, and they're the largest a large provider of Medicaid and Medicare populations. They still a lot of times see uninsured, but they're not one of the larger uninsured because many of the RHCs are for-profit entities. The location requirements. FQHCs have to be developed in an underserved area or be serving an underserved population, okay? What it breaks down to is they need to be in a health professional shortage or medically underserved area, or be able to clearly demonstrate that the people that are coming to their clinic are from those health professional service areas or medically underserved areas. That is a big difference in the two clinic types. FQHCs can be rural or urban. They're not limited to just rural areas. We see lots of FQHCs. We have several in Baton Rouge. We have several in New Orleans. And then they have satellite sites in smaller areas. And we see some small FQHCs that are core sites across the state. RHCs have to, by definition and by regulation, must be in a rural area when they are developed. And that is defined by the U.S. Census Bureau. The U.S. Census Bureau definition of rural. They have to be in a health professional shortage area. And a current health professional shortage area. That's a CMS regulation, and current means within the last 4 years to the end of the year. The uninsured. The FQHCs are larger providers compared to the uninsured Medicaid population. For that, they receive a Public Health Service Act 330 grant for a portion of the care to the uninsured and the underinsured. That does not cover any and all. In our state, it's about 33% of their overall budgets. In the South, it's much larger percentage than what it would be in the North. It's important to remember also, FQHCs are not free clinics. They are allowed to have a minimum fee, okay? And it may be a minimum fee difference. It may, for primary care, it may be $20. If they can show that the patient has a source of income. Now, most FQHCs, they have a policy of the truly, unemployed, homeless person, they go down to zero under certain circumstances, but they are allowed to have a minimum fee. A lot of times that's a confusion between people that think, oh, well, I just send the uninsured there because it's going to be no cost. That's not necessarily true. That model is gone. The RHCs are not required to see an uninsured population. They're a large provider to Medicaid and Medicare populations. The financials, they've changed a little bit recently. Both were getting fee for service. Now there's been some huge changes with how FQHCs are paid. The most important thing is the RHCs receive this 330 grant for a portion of the care of the uninsured and underinsured. RHCs do not receive that, so you can kind of understand why they don't see as much uninsured. They're not getting that extra funding to see the uninsured. Some RHCs, about half in our state, are owned by rural hospitals, and rural hospitals that are under 50 beds, they're cost-based, which means there's not a cap for their Medicare patients. It's based on the cost of the patient. So you'll see that there's some differences. And some of our small rural hospital-based RHCs have significantly higher Medicaid rates that was set by our Louisiana legislature. And those, because they were hospital-based, the legislature decided to give them a higher rate because it was to keep the hospitals sustainable. Quality and reporting, huge differences. FQHCs have a uniform data system report. It is very, very intense. They must have one quality initiative. Those change each year. They're required in their initial application to have one clinical measure up front, at least one. Most of them have many, many. RHCs, remember that an RHC is typically a nurse practitioner and a part-time medical director. There are currently no set quality measures that are required to be reported. Now, I do really believe that that's coming, and they are working with many rural health clinics to develop what those are. But at this point in time, there are no required quality measures for RHCs. Now we're going to get into why we serve. This is an important thing. We know from National Rural Health Association and different organizations that essentially only about 11% of physicians practice in rural areas, yet nearly 20% of our population live in these areas. In Louisiana, 39.7% live in rural areas. We know that rural residents tend to be poorer, rely more heavily on the Supplemental Needs Assistance Program, or what we used to think of as food stamps. They're less likely to have employer-based insurance coverage. They have higher rates of hypertension, smoking, tobacco use, suicide, and serious injury. There are a lot of factors that make a huge difference between rural and urban. That's why what we do every day, what we do. We know that they tend to be poorer, and there's data that shows that in the poverty rates. We know that they tend to be sicker. The CDC has tracked this. They have higher rates of heart disease, cancer, stroke than their urban counterparts. And there are a lot of other factors that I could have included and gone on and on and on about obesity rates and strokes and different things like that. But that's the core of why we do what we do. I'm going to open it up for questions. The very last slide is going to be our contact information. And please know that there are more webinars coming. There will one I will be specifically doing into the in-depth of technical assistance for anybody that's interested in that. And then our other offices within the Bureau of Primary Care will be doing webinars as well.
This is Nicole Corsi. If you do have a question, you can use your chat feature and type your question out. You can raise your virtual hand, and if you dialed in to the webinar via a phone, I can unmute your microphone and you can ask your question. We're going to give a minute or two to see if anybody has any questions. Again, I see somebody has chatted one. The question is, will the slides be shared with the participants? Yes, we will be sending up a follow-up email with participants, and we will include a copy of the slides for you to have.
If you are like me, generally about midnight, I'll have 100 questions that I thought about during the day and finally hit my brain. If you have those questions, please feel free to email me. That is what we do every single day, is help to answer those questions and make people successful that are working in and with rural areas.
We're going to try to get this video also. We recorded this, so we're going to be posting a link to this presentation on our website for future viewing as well. After the session is over, you will receive an email requesting you to complete an evaluation on this webinar. It's, I believe, 4 simple questions. If you could just take a minute to complete that evaluation, that'll help us with future planning of these webinars.
And please note any kind of issues you have. I'm very, very open to feedback, and I appreciate it. If there's no further questions, then we're going to wrap up. You guys have our contact information. Feel free to contact us at any time. I couldn't do this without everybody else helping. Our director, Avis Richard Griffin, Nicole Corsi, who is our emergency preparedness specialist, is awesome at that. Any of you that need that information, please either contact me or contact her. Denise Dowell, who is our community developer and who I often refer to as the right side of my brain because she keeps me together and focused, and lots of other people in our office and within OPH and LDH. All right, thank you guys, and we will be letting you know soon of the next webinar.